care of perinatal anxiety and depression into your obstetric practice. And this has become a lot more relevant and necessary during the pandemic, where mental health resources in general, but especially perinatal mental health resources have been stretched really thin. And I do want to clarify that for this talk, I will be using the general terms anxiety and depression to really stand for the range of anxiety disorders and the range of depressive disorders described in the DSM-5. So because most of us all are obstetric providers and not psychiatrists. So I thought that it was a more useful terminology to use. So I have no relevant disclosures. And I'm going to start with a patient case just to introduce the clinical scenario. So this is a patient I've taken care of in the past year. She's a 36-year-old nulliparous woman with lupus on Plaquenil, who at her 12-week prenatal visit reported that she was having worsening anxiety. In her own words, she said, "I can't quiet my mind." She's having difficulty sleeping, and she's also feeling sad. When I asked her about a little bit more about what she would do, how long she'd been having these symptoms and what how she was doing before she got pregnant, she reported that she had been using Xanax as needed, usually a couple times a week, and especially during the pandemic, started drinking regularly, usually 2 to 3 drinks a night, which she had discontinued when she got pregnant. She also has a more remote history of episodic depression and panic attacks. So we're going to talk through a practical framework that will hopefully help you address this kind of patient situation and others related to it. And we'll start with antenatal screening, which is a really important part of this. Then we'll talk through some clinical pearls for non-pharmacologic therapy, somatic treatment, treatment of somatic symptoms, and then also antidepressant therapy or pharmacologic therapy, followed by some tips about what to do for follow-up. And I've included breaks after each part of this framework to allow for questions along the way, which you can type into the chat or the QA box. So pearl number 1, screen all pregnant patients for depression and anxiety antenatally. Our governing professional organizations do recommend screening for perinatal depression. And I'm going to go through what each of them says. So this is just taken verbatim from the recommendation. The USPSTF recommends screening for depression in the general adult population, including pregnant and postpartum women. That's coming from the U.S. Preventive Services Task Force. The American College of OBGYN recommends that obstetrician gynecologists and other obstetric care providers screen patients at least once during the perinatal period for depression and anxiety. The American Psychiatric Association recommends screening for depression with a validated screening tool twice during pregnancy, once in early pregnancy for pre-existing psychiatric disorders, and once later in the pregnancy. And we also recommend postpartum patients be screened for depression during pediatric visits throughout the first 6 months postpartum. And then the American Academy of Pediatrics also recommends integrating postpartum depression surveillance and screening at the infant visits at 1, 2, 4, and 6 months. So what is the rationale behind screening for depression and anxiety antenatally? And I'm going to go through a series of points, each of which has its own body of literature behind it. So first of all, it's prevalent. The depression, anxiety in pregnancy is very common, and estimates range between 1 in 7 to 1 in 10. Depression and anxiety are associated with adverse perinatal outcomes. These are 2 meta-analyses that were done looking at the effect of looking at pregnancy outcomes, comparing patients with untreated depression to patients without depression. And the odds ratio for preterm birth was 1.56, and the odds ratio for a low birth weight in patients with untreated depression was almost 2. And then in a different meta-analysis looking at anxiety, patients with prenatal anxiety versus patients without, the relative risks were 1.5 and 1.76 for the same outcomes. Screening and intervention for perinatal anxiety and depression has been shown to improve depressive symptoms. And this finding has been consistent across studies, although the magnitude of the effect has been variable depending on the study. And antepartum interventions have been shown to improve postpartum outcomes. And then finally, there's a large body of literature looking at the association of postpartum mood disorders with long-term developmental issues in the offspring, both psychiatric, behavioral, and then also relationship issues, attachment issues. In addition to the prevalence of perinatal anxiety and depression, its association with adverse pregnancy and neonatal outcomes, and the demonstrated benefit of screening and intervention, self-harm is a significant cause of pregnancy-associated mortality and is additional reason to be screening for these disorders, and especially in the younger patients and in the postpartum period. So I'm going to go through 3 case series briefly that have looked at maternal deaths in the US in the past 5 to 10 years. And you'll notice a large variation in the estimate of the impact just due to methodological differences in the studies. But this review of 9 maternal mortality review committees showed that suicide was a cause of 7% of pregnancy-related mortality. In this case series of pregnancy-associated deaths in California, they actually showed a much higher rate, so 18%, but they included overdose in that estimate. But 18% were due to overdose or suicide. And then in the case series in Colorado, which was a little bit more intensive in terms of looking at the actual cause of death, the rate was even higher, so 30% were due to overdose or suicide. And despite the variation in these findings, I think it's clear that the burden of preventable deaths due to mental health in pregnancy or in the first year postpartum is significant. Another compelling reason to screen all patients for anxiety and depression during pregnancy is the evidence that screening itself can improve symptoms even without any major intervention. And that's because the screening studies that had minimal intervention, apart from maybe some education and a conversation with the patient, still showed improvement in depressive symptoms later on. And it's probably because identifying depressive symptoms and discussing them with a patient can lead to the patient being a better advocate for him or herself and galvanizing social support. There was a qualitative study in South Africa where they actually interviewed 55 pregnant women at 2 different time points in pregnancy. Basically they screened them using the EPD, the Edinburgh Perinatal Depression Scale, and then talked to them again at another point in the pregnancy just to see what the impact of the screening had on them. And these were the themes that came out of those qualitative interviews, where patients basically said that disclosure itself gave them an outlet. The anonymity was really appreciated to be able to talk about these issues with people outside of their lives. They felt validated by the conversations. And then just having increased self-awareness made it possible for them to identify issues themselves earlier on. And also gave them the agency to disclose their feelings and address issues with family members and friends. And this, I think this is a compelling reason, especially when some people say that we shouldn't be screening because we don't have the resources to deal with positive screens. But I think this shows that there's definitely evidence that says that even the screening itself does have a therapeutic effect. So the next question, of course, is how do we screen? And the recommendation is to screen with a validated screening tool, ideally the Edinburgh Postnatal Depression Scale, which is recommended in pregnancy and postpartum. It's short. It requires low health literacy. It's recommended by ACOG and the US Preventive Services Task Force. And it's specific to the perinatal period in that it doesn't include the constitutional symptoms that are usually included in the other depression screens, as those are very common issues in pregnancy and not specific to perinatal depression and anxiety, so sleep and appetite. It's also easy to score, and it's translated into many languages. It's also has been validated in multiple languages. So in these 18 languages, at least, with specific cutoffs that have been determined for each culture to be predictive of depression. Ideally, the screen should be administered in writing. There's evidence for other cases, for example, domestic violence screening, food insecurity screening, that patients are more likely to disclose vulnerable information in writing than verbally. And then ideally any concerning responses are reviewed in person with the patient. The EPDs, in addition to screening for depression, it does have an anxiety subscale. So questions 3 to 5 specifically address anxiety, which is often comorbid with depression. And the scoring in the literature, there are different cutoffs that are used to indicate a positive screen. The minimum score, of course, is 0, the maximum is 30. And based on the validation studies, greater than or equal to 10 is possible depression, greater than or equal to 13 is probable depression. So the other question with screening is when exactly to do it. And if you look at these guidelines that I showed you a couple minutes ago, you can see that they're pretty variable, and actually ACOG is the least specific in terms of timing of screening. And when you consider the evidence that we have on when perinatal depression starts, there come a couple of studies that have looked at, have asked patients when their symptoms started. And a significant amount of the time, the symptoms actually start before birth, either before pregnancy or in pregnancy. And there was a study that compared the characteristics and risk factors of pregnancy onset versus postpartum onset depression. And these were the risk factors that the study authors found to be more common in patients with onset during pregnancy. So low social support, a history of abuse, an unplanned pregnancy, a history of major depression, especially non-perinatal depression, and then the history of discontinuing an antidepressant within the past year. So in looking at the evidence and the guidelines from the different professional organizations, my recommendation is to screen all pregnant patients for depression and anxiety antenatally using the EPDs with a cutoff of 10 or greater to denote a positive screen. And I would suggest this timing. So doing an initial screen early in pregnancy, a repeat screen in the 3rd trimester for patients at risk, either because of risk factors or because of your clinical assessment. And then repeating it after birth, for patients at risk shortly after birth, and then for everyone at 6 to 8 weeks after birth. And Medicaid does reimburse for maternal depression screening. I think otherwise it's included in the global fee. And then if we go back to the framework that I introduced earlier, we just finished talking about antenatal screening, universal antenatal screening, using the EPDs at 1 to 2 time points, in addition to the postpartum screening. And the recommendation for antenatal screening using the EPDs is a grade B recommendation from the U.S. Preventive Services Task Force, which means that there's moderate to high certainty that the benefit is moderate to substantial. So now, quick moment for questions on this first topic, first Pearl.
People can place things in the chat, or they may even be able to unmute themselves, but maybe not.
Okay, then I'm going to go on. So Pearl number 2 is to maximize non-pharmacologic methods, in particular therapy. So in a survey of pregnant patients, almost 500 patients that were completing depression screening, they basically asked what the preferred depression treatments would be. And as you can see, the majority indicated a preference for therapy as treatment for depression in pregnancy. And the good news is that that is the best studied and most evidence-based non-pharmacologic intervention for anxiety and depression. In a systematic review and meta-analysis by the U.S. Preventive Services Task Force, they showed that there's benefit in cognitive behavioral therapy in the treatment of perinatal depression. And they showed that there was both an increase in the likelihood of remission as well as an improvement in depressive symptoms as measured by whatever screening tool was used in the studies. And in the studies that had longer term follow-up of up to a year, the pooled analysis showed a 35% increase in the likelihood of remission at 1 year with cognitive behavioral therapy. Another more recent systematic review and meta-analysis by the U.S. Preventive Services Task Force showed a role of cognitive behavioral therapy and interpersonal therapy in actually the prevention of perinatal depression in women at risk. And you can see here the numbers of the participants. So these were much higher, not much bigger studies than the ones used for looking at the treatment of depression. And they showed a significant reduction in the risk of developing postpartum depression with CBT and interpersonal therapy. So the grade B recommendation, again, from the U.S. Preventive Services Task Force is that CBT and IPT be used in the treatment and in the prevention of perinatal depression in patients at risk. Other interventions have been shown to have benefit in small studies, but they were either not significant in pooled analyses or not included in that meta-analysis due to low numbers in those original studies. And just to go through them, so physical activity, case management, or health systems interventions, most of these studies were actually done in other countries and involved home visits. Educational interventions, yoga, and other complementary medicine, alternative medicine, peer support, and infant sleep interventions. Mindfulness techniques are often included in therapy, but I wanted to specifically mention the option of digital mindfulness aids. And these are more recent tools that have been developed. But there are some recent pilot studies that suggest that digital mindfulness aids can actually improve depression and anxiety. And there are two done in the past year that showed feasibility and acceptability of this in pregnant women. So there's one study from the Kaiser Permanente system, the low number of patients, but they use the Headspace app, which is publicly available. And it is a 10 to 20 minute module that you are supposed to do daily for 6 weeks. And it showed improvement in perceived stress and depressive symptoms 6 weeks later. There was another study coming out of Germany just looking at pregnant hospitalized patients, and they developed their own app, the study team did, and they showed a decrease in anxiety only 1 week later. Bright light therapy is another tool that has mixed evidence in terms of its effectiveness, but it's very inexpensive, it's very accessible, and there's no fetal harm. And then the final thing I wanted to mention is that counseling on self-care is something that you as the obstetric provider can initiate immediately, and it can be particularly helpful if the trigger for the anxiety and the depressive symptoms is pregnancy related and thus time limited. So for example, after a loss, or in the setting of a history of a pregnancy loss within a subsequent pregnancy. For patients, focusing on kind of the physical and the logistical aspects of self-care can be a distraction from their thoughts and feelings related to a loss, for example, and can provide physical comfort, especially if there was a particularly difficult time, for example, in someone who had a loss at 23 weeks, getting through that point in the pregnancy, in a subsequent pregnancy. And it can also act as a bridge until the patient can be seen by a mental health provider. So talking about diet, hygiene, making use of social supports, building a healthy routine, other things we had mentioned like yoga, massage, acupuncture, and exercise. In that same survey of patient preferences for treatment in pregnancy, these were the reported barriers, so patient-reported barriers to getting professional help. And in terms of the screening and providing the initial response, pharmacologic or non-pharmacologic, we can overcome these significant barriers of stigma and not knowing where to get services and concerns about cost. And for those of you that work in settings where you don't have social work readily available to help find resources, then MCPAP for Moms is a wonderful state-funded resource that can help identify therapists and support groups and such, as well as perinatal psychiatrists. And then in terms of the other barriers, time, childcare, transportation, digital aids, like I mentioned with mindfulness aids, telehealth and case management for patients with little resources can help overcome these barriers, especially when we're talking about non-pharmacologic therapies. So to recap this second pearl, I recommend maximizing non-pharmacologic methods, in particular CBT and interpersonal therapy, as the most evidence-based therapy that we have. The other tools should be individualized depending on the patient preference. They all do require patient motivation and commitment, other than case management. Sorry, I just did something here. And same with alternative medicine. I think patients' perspective on that before they initiate therapy it has a big impact on how they respond to it. And then, like I mentioned, counseling on self-care is kind of a short-term way to get to a bridge to either get through a certain time for the patient or to get to bridge them to seeing a mental health provider. And then going back to the framework, CBT as therapy for perinatal anxiety depression is a grade B USPSTF recommendation as well. And due to its role in both treating and preventing perinatal depression, I would, again, advocate for using a cutoff of 10 for the EPDs rather than a higher one to refer a patient for treatment. Questions about that?
There was one just in the chat, Leanna, the challenge about finding therapists and providers, long waits, insurance coverage. You mentioned McPack for Moms. How good is that in actually finding resources for people?
My understanding is that they're extremely helpful. The thing is they only take referrals by phone, not by email. And it has to be between 9 and 5, Monday to Friday. But since they're a statewide resource, they have, listings of people, I think by providers, by area, and by insurance that they take.
Thank you.
Great, so I'm gonna keep going. So next, the pearl number 3 is treat somatic symptoms. So patients with anxiety and depression are much more likely to have physical complaints, GI upset, and especially with depression, severe constipation, pain, so in pregnancy, abdominal pain, pelvic pain, headaches, and other potentially normal symptoms in pregnancy that may be more distressing due to their mood issues. And I am going to focus on sleep disturbance, treating sleep disturbance. And I would encourage everyone to inquire about sleep disturbance in their patients with anxiety and depression. It tends to be an important part of the treatment. It's good to start by getting a sleep history and evaluating for other causes. Thyroid disease, cardiovascular. So if this is an extreme example, but someone with pulmonary edema is not going to be able to sleep well. Genitourinary issues, someone with a bladder infection or incontinence is more likely to get up for that reason and not necessarily because they can't sleep. And then of course, obstructive sleep apnea, and of course, encourage a timely evaluation for obstructive sleep apnea if there are risk factors. So sleep hygiene is not recommended as a first-line intervention, but I listed it first because it can be started immediately and you can counsel the patient. Counseling the patient about a regular sleep schedule, starting a sleep, kind of a routine that initiates the going to bed earlier than they're probably doing, limiting screen time before bed, minimizing caffeine, keeping the room dark and cool, and keeping the area where sleep is supposed to occur purely devoted to sleep and not to other things. Really, the first line treatment is cognitive behavioral therapy for insomnia. And this is recommended by the American Academy of Sleep Medicine. There are digital versions now that have been shown to have an impact on sleep, as well as on depression and anxiety symptoms. And there's a lot of data from the non-pregnant population, but there's also a randomized controlled trial looking at the impact of digital CBT for insomnia in pregnancy. And there are multiple digital versions available. In this RCT, they use Sleepio, which is an evidence-based but very expensive app. I have used this app with patients, CBT Coach, because it's free. It's not designed to be, take the place of in-person CBT or in-person help, but it's a good adjunct to help with patients with sleep disturbance. And this is what the home screen looks like for the app. And when you click on the tools box, it comes up with this tools menu. And under each of these subheadings, there are a series of modules that users can try and then can continue using depending on what's helpful. And quiet your mind. So there are different, like there's imagery, there's one module that shows you different imagery, music, breathing exercises, all of that. And then finally, there are pharmacologic options, which may be necessary, especially in some cases short-term, until either certain life events have passed or medication has started, therapy has started to have an impact. Over-the-counter antihistamines are excellent starting points, of course, to help initiate sleep. So either Benadryl or Unisom, doxylamine, melatonin is a supplement that can help with sleep initiation as well. And then there are a series of antidepressants with sedative effects that can be useful. And the nice thing about them is that when you're using them for sleep, you really need very small doses to be effective. Of these, Seroquel is the best studied in pregnancy. It can also help with anxiety symptoms and with nightmares. But you do have to be aware of drug interactions since it's a QT prolonging medication. Mirtazapine is an antidepressant that can be quite sedating. It can help with nausea and anorexia as well in patients with significant nausea vomiting of pregnancy or hyperemesis. Trazodone is an antidepressant that's often used at night, again at lower doses to help with sleep and with mood. And then benzodiazepines and Ambien, we usually don't recommend using in pregnancy. They have to be used with caution and, in certain cases, and usually in small doses, sporadically, short-term, due to their addictive potential. And Ambien can also be, it's more specific than benzodiazepines, but can cause short-term amnesia. So you want to be careful with using it. So the third pearl from today is to treat somatic symptoms in patients with anxiety and depression, and specifically sleep disturbance, with CBD for insomnia being first line, and sedating antidepressants also being effective options for these patients. And in our framework that we have here, with my suggestion here to specifically address sleep in these patients, the recommendation for CBTI is a practice guideline from the American Academy of Sleep Medicine, as I had mentioned before. Any questions before we move on to antidepressant therapy?
There are two questions in the chat, Leanne.
Yeah, I'll feed them to you, Leanna.
Okay.
The one is melatonin indicated in pregnancy?
It can be used. There aren't any known harmful effects to the fetus. I think usually I have only used it in patients who have used it before when they had sleep issues before they got pregnant. But it can be used.
All right, next, another question is for sleep and anxiety. What do you say about CBD tinctures?
About what? CBT pictures?
CBD, I think we're talking about.
Oh, tinctures.
Cannabinoids. Yeah.
Yeah, so this is a very controversial topic. The problem is that we don't know, most of the data we have for marijuana in pregnancy does not separate out THC, the kind of psychedelic part of the drug, from cannabis. And I usually caution against using them because we don't know without separating them out what we think that probably the THC is the more harmful component in terms of fetal brain development, but we don't know for sure. And so I usually caution against it, saying that we don't think it has any impact on pregnancy outcomes or immediately on the neonate, but it has been shown to be associated with adverse neurodevelopmental outcomes longer term. Although of course the studies are also limited in terms of confounders. There are patients who swear by using CBD oil or other such tinctures, and generally in those cases I counsel them that about what I just said, and I also think my guess is, although again this is not proven, that smoking marijuana is going to be worse than using cannabis only and using it in a way where you're not inhaling it, because you're not having we worry more about kind of a similar effect as tobacco if they're smoking it in terms of pregnancy outcomes. But I found that patients in general are either extremely committed to using CBD or happy to give it up, and so I have not found really that my counseling at least has made that much of a difference. I don't know for those patients. I don't know if anyone has a different experience, but.
Thank you. And then one final question. What about benzodiazepines for our hospitalized antepartum patients? Sometimes that becomes kind of a reflex on admission. It sounds like you may have more caution against that because of the addictive potential.
Yes, I think that ideally we should be using other methods first and saving benzodiazepines for more acute situations, and definitely not kind of have it be a reflex for our patients that are hospitalized.
Great. And then one final comment from Dr. Kiefer about MCPAC for moms. They also can connect you to a psychiatrist on the phone to formulate an initial treatment plan just for the group.
Yeah, and we'll talk more about that next. Great. So the fourth pearl is when we're talking about antidepressant, so pharmacologic therapy, we need to be balancing the right fetal exposures. So we're balancing the fetal exposure to medication versus the fetal exposure to untreated maternal anxiety and depression. So the first step in terms of considering antidepressant therapy is generally it's not a good idea to discontinue pre-pregnancy treatment. And some of this decision-making is of course going to depend on when you're meeting the patient. Are you meeting the patient before conception? Are you meeting them in the first trimester? Are you meeting them in the third trimester? But patients who discontinue their psychopharm in pregnancy have a high rate of relapse of depression. So 70% of patients who discontinued antidepressant therapy in pregnancy have relapse. And that the rate of relapse for patients who maintain medication is not insignificant either. It's also pretty high, 26%. Just goes to show that pregnancy is a vulnerable time for these patients. And then another reason not to just discontinue pre-pregnancy treatment is that many of these medications have to be tapered pretty slowly to avoid rebound or withdrawal symptoms. And just going back to this risk of relapse, in that Colorado series that I went through a couple of minutes ago of pregnancy-associated deaths, half of the deaths due to self-harm were in patients that had discontinued their psychopharm in pregnancy. So there's significant implications for maternal mortality as well. Some medications I wanted to just draw your attention to because they require a little bit more of a weighing of the risks and benefits due to a concern for teratogenic or postnatal effects. And this is not an exhaustive list, but there are medications that are more commonly used for mood disorders. And as we go through them, one more thing of note is that even with these medications, there are situations where they are the best choice for the patient. So lithium, used as a mood stabilizer, usually used for patients with bipolar disorder. And the best, largest study that's been published showed a relative risk of cardiac malformations, most notably of the right ventricular outflow tract of 1.65. So definitely there, but not as high of an increase as had been previously suspected. Topamax or topiramate is also sometimes used as a mood stabilizer. There have been reported increased risks of a cleft palate. Whenever you're seeing a patient who's on medication with this concern, you have to remember that the palate is done forming by around 9 weeks. So if you're meeting the patient at 12 weeks, there's no point in stopping their medication for this reason, at least. Paroxetine is an SSRI that has had mixed data, but there are some studies that report an increased risk of cardiac malformations. So if you have a choice and you're starting a patient on medication before a planned pregnancy, we usually would not recommend starting paroxetine. Benzodiazepines, there are data that suggest there might be an increased risk of cleft palate. Like I said, it depends on when you're meeting the patient as well. Otherwise, the concern with benzodiazepines is that if you are stopping the medication, you have to do a very slow, long taper to avoid rebound symptoms. And of course, the worst case scenario, seizures. And if necessary, if the patient, after weighing risk benefits, getting a good history, if it seems like the patient needs benzodiazepines, it's better to have a patient on lorazepam rather than a longer acting benzodiazepine like diazepam. And it's worth making that switch in pregnancy because also for breastfeeding, it's better to have a patient on a shorter acting benzo than on a longer acting one. And then I would still say that benzodiazepines are options in pregnancy for short-term or as needed therapy. In terms of, the risks of neonatal withdrawal symptoms, they actually are not as severe as they've been thought to be in the past and are self-limited. Usually have to be on pretty high doses and consistent doses to have the neonatal symptoms. And then just to mention for SSRIs, they're very well studied in pregnancy and are not thought to be teratogenic, but exposure after 20 weeks does increase the risk of persistent pulmonary hypertension in neonates. You can see this was the largest study done to date and showed that while the risk was certainly increased, the absolute risk is very, very low. So in patients, in babies exposed to SSRIs in utero, the risk of pulmonary hypertension was 0.3% compared to 0.2% in babies not exposed to SSRIs in utero. So I would recommend initiating an antidepressant in these situations. If you have a patient who has moderate to severe symptoms, if there's comorbid anxiety and depression, and or if there's a history of severe depression or a suicide attempt. And the McPap for Moms toolkit has a really useful chart in it that shows the EPDs scores with a gradation of symptoms and examples of what patients symptoms patients may experience in these different categories, just to help you decide, how severe a patient's symptoms may be when you're considering whether they would benefit from their pharmacologic therapy. And then the general principles in prescribing these medications is You always want to ask first if they've used medication in the past, and if something has worked in the past, that should be the first medication you start again. You want to screen for bipolar disorder, and there are a couple of screens available online, also at the MCPAP for Moms website, basically asking about a history of mania. Ideally monotherapy to minimize exposure, fetal exposures. The lowest effective dose, and the important part of this is effective. And then there's no reason to discontinue medication before birth. If anything, that would be a disservice to the patient, because that tends to be a very tumultuous and vulnerable time. And so then you're just increasing the risks again for afterbirth. I would strongly recommend referral to psychiatry if there's any indication of psychosis, suicidal ideation, or if you're not sure if the patient has bipolar disorder. And then this is what Zoe was referring to. The MCPAP for Moms toolkit also has a really useful algorithm that walks you through initiating and also titrating therapy. And I would really recommend you use it as a reference if you're not used to prescribing these medications. And we'll go through a couple of points as well for SSRIs. So SSRIs are first line for depression and anxiety. And the SSRIs I'm talking about are sertraline or Zoloft, fluoxetine or Prozac, citalopram or Celexa, and escitalopram. And like I said, they were very well studied in pregnancy. The retrospective studies of pregnancy outcomes in pregnancies exposed to SSRIs are limited because of the underreporting of substance use in these studies, and specifically talking about tobacco, marijuana, and alcohol. They're usually underreported. And then, of course, there's a lot of confounding by indication and environmental factors that play a role that are not measured or reported in the studies. There have been studies that have actually looked at sibling comparisons. And in those sibling comparisons, the association of SSRIs with preterm birth and small for gestational age infants are no longer significant. And when in counseling patients about the use of SSRIs, of course, something that other than talking about that risk of pulmonary hypertension, which is present but very, very small, it's important to talk about poor neonatal adaptation syndrome, which is usually self-limited, resolves within a few days, and is very rarely severe. The risk of symptoms in the neonate is much higher if the doses of the SSRI are high, and they're a little bit higher with SNRIs than SSRIs. But the first line is Zoloft or sertraline because it has a shorter half-life than the other ones, and the breast milk studies have showed least amount of transfer. We talked about not choosing paroxetine as a new agent. Fluoxetine can be more effective than the other ones if anxiety is the predominant issue. And then if you're using an SSRI to treat anxiety, you will tend to need higher doses than if you're treating depression. The side effects, I think, are really helpful to prepare the patient about when you're starting an SSRI, especially the short-term side effects, because they usually resolve on their own within a few days to a week. And you don't want a patient self-discontinuing a medication just because they weren't prepared for the possible side effects. So the short-term side effects are lightheadedness, headaches, and GI upset. Longer-term ones are weight gain, loss of libido, dreams, and sleep disturbance. And I usually don't spend a lot of time talking about these because it's unclear how long patients with perinatal anxiety depression will need medication. So to summarize the fourth pearl, I recommend balancing the relevant fetal exposures when you're considering antidepressant therapy and also when you're counseling the patient. Generally, pre-pregnancy treatment shouldn't be discontinued. And SSRIs are first line in terms of pharmacologic therapy in patients with moderate to severe symptoms. And in our framework that we've been kind of filling out, these are expert opinion, not just mine, but published, not the same level of evidence as these others that we talked about, but I think worthy of following, given the evidence that we have. Questions?
Nothing in the chat or QA just yet. I'll feed them to you as they show up. All right, one from Dr. Kiefer, risks of postpartum hemorrhage and preterm labor with SSRIs. Do these exist and how would you cancel them?
So those have been reported, but I think that there must be, it doesn't make sense to me why that would be. So I think there must be, basically other reasons like confounders or covariates that are associated with both that are actually, I don't think there's a causal relationship between SSRIs and that outcome.
Nothing else in the chat or QA that I see right now.
Great, so we don't have much time left, so I'll just keep going. So my final pearl or recommendation from today is to serially document EPDs score and mood for patients with perinatal anxiety and depression. And I'm just going to go through a couple of practical tips from my own practice that I found helpful. First, using the EPDs in monitoring these patients and monitoring response to treatment is helpful as an adjunct because it's relatively objective and it's quantitative, and you can use it kind of like a vital sign. When you're doing your clinical assessment, always, of course, important to ask about mood and document that in the patient's own words. Checking in often. So making use of telehealth and also involving different members of the care team, your nurse, your social worker, other treaters. And when you're looking at response to treatment, it's of course important to screen for or ask about suicidality and mania, because there's a small subset of patients that will experience those as adverse reactions to SSRIs. Budgeting extra time at visits for those patients is helpful. And then involving collaterals can be key, especially when you have a patient with a known psychiatric history that's pretty complicated, and you're meeting them in pregnancy for the first time, and they have a long pre-pregnancy history. You do have to obtain patient consent, but being in touch with other treaters, their partners, family members. So this last part was really just, some practical tips, like I said. And now that we've reviewed the recommendations I have for you in this framework with varying evidence bases, let's go back to the case. So for her, antenatal screening was not relevant. We actually neglected to screen her at her first prenatal visit, but she brought up, thankfully she brought up her symptoms herself. We did end up referring her, so the first thing we did was refer her to one of our social workers who does therapy, and she started weekly sessions with her. She did have a prior therapist, but that prior therapist didn't have the skill set to deal with her current symptoms. She had already been practicing some mindfulness techniques, and so I gave her the information about the CBTI app, which ended up being a good aid for her in terms of, an adjunct to what she had been doing already. And it was nice for her to be able to access this additional support from home. With regards to medication, we did not recommend resuming alcohol and Xanax. We considered Seroquel, but unfortunately it's a QT prolonging medication and she's on Plaquenil, which is also QT prolonging. So we ended up deciding on mirtazapine, and we started her on 15 milligrams, so very low dose QHS. And then with regards to her follow-up, we scheduled her for visits every other week, alternating in-person and telehealth appointments. And she did really well. She had improvement in her sleep within the first week, and her mood improved within a few weeks. And I can't say that any of these things alone had that difference, made that difference, but everything together, I think, worked really well for her. So just in summary, screen all patients, all pregnant patients for anxiety and depression antenatally, and this was my suggested schedule. Maximize non-pharmacologic methods, in particular therapy or CBT, both because of the evidence base, but also because it's a patient preference in pregnancy. Treat somatic symptoms, specifically sleep disturbance. Balance the correct fetal exposures, so medication versus untreated mood disorders. And then serially document EPDS score and mood in patients with perinatal anxiety and depression, and in patients who are at risk for perinatal anxiety and depression. And then these are our references for today. And I want to thank you for your interest and your attention. And I'm available by email if you have any questions you want to ask later, or any specific patient questions, always happy to talk. But otherwise, if there are any questions now, I'm also happy to answer them now.
We have one more in the chat. There are anxiety-related and anxiety-specific screening tools, and how do you compare them against the EPDS anxiety subscale?
There are. They haven't been used in clinical practice as much as the EPDS. So the state trait anxiety inventory is probably the most commonly used anxiety scale. It's not pregnancy specific, but it hasn't been, while it's been validated in pregnancy and used in research, it hasn't been used in, it's not commonly used in clinical practice. So I think a major barrier there is the education and knowing how to apply it in clinical practice.
And I see no other questions.
Okay.
Well, first of all, I wanted to thank you. That was a phenomenal whirlwind of an hour. I think we all learned something. Thank you for your expertise in this and caring for our patients, and being a resource for us. I also want to personally thank you for bringing attention to the problems of anxiety and depression in our hospitalized antepartum patients as well. Your efforts to understand that a little bit more. So thank you, Dr. Suda.
Thank you. Have a great evening. Bye.